Hi, everyone. Thank you so much for joining the second session in our Age-Friendly Geriatrics education series on cognitive impairment. As you know, this series has been organized for you by the UCI Division of Geriatric Medicine and Gerontology and our Geriatric Workforce Enhancement Program. Thank you so much for joining us today. I know we'll have others joining us along the way as we start introduction. So come on in, more the better. So this is our main structure of our echo sessions. We're just going to be starting with introductions and announcements followed by our didactic. Today's didactic is going to be focusing on supporting family caregivers in primary care. And then we have a wonderful case submitted by Dr. Wall that we will be reviewing as well. And Dr. Harvath, who is our didactic presenter, also has some additional cases to review as well. And then we'll go into our closing and reminders. Just to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. We're going to go ahead and just do introductions via the chat for our attendees. Make sure that you're always maintaining confidentiality when speaking about your patients and refrain from including any identifying information. As you all know, our series is CME accredited. This session is accredited for 1 CME credit. If you do attend all sessions in our series, you will receive 5 CME credits. CMEs are usually do receive reciprocity through the California Board of Registered Nursing as well, just so that you are aware. Our series is a part of our HRSA Geriatric Workforce Enhancement Program, and one of our main goals for this grant is to train geriatric specialists, primary care providers, and health professions trainings to help expand our geriatric workforce. So thank you again for attending this session. So we'll go ahead and move on into introducing our hub team, but if you are on the line, please go ahead, our attendees, please put in the chat your name, your role, your site, and your location. We love to see where you are all joining us from today. But I will go ahead and introduce myself. My name is Nika Seville. I am the project manager for our Geriatric Workforce Enhancement Program here at UC Irvine, and we're located in Orange County, California. I'll go ahead and move to Dr. Sagal.
Hi, everybody. Welcome. I'm Sonia Sagal. I'm a clinical professor in the Department of Internal Medicine and Division of Geriatric Medicine and Gerontology. My practice site is at the UCI Senior Health Center, which is located in Orange. It's my pleasure to be with you today.
Thank you, Dr. Sagal. And Dr. Campbell.
Hey everyone, my name is Sarah Campbell and I am a clinical professor in the School of Nursing here at UC Irvine and also a family nurse practitioner. I also practice on site on campus, actually at the Student Health Center currently, and love to see you all here. So thank you for being here today.
Thank you. I don't see Dr. Geriatrics on yet, but I know she'll be joining us. Dr. Geriatrics, are you on? I think she'll be joining us in a little bit. Thank you. So let's see who's on the line. I see Dr. Diaz-Mbuja, who's from UCI. We have somebody from Chino in the Inland Empire. We have Crystal Frantia from Orange County. Let's see, from Laguna Beach, from Wyoming, all over the place. So again, thank you all for joining us today. If you haven't already introduced yourself in the chat, please do so. So I have the pleasure of introducing our didactic speaker today, Dr. Terry Harvath. Dr. Terry Harvath is a professor and the Senior Director for Strategic Initiatives at the Betty Irene Moore School of Nursing at UC Davis. She's also the founding director of the Family Caregiver Institute at the School of Nursing, which strives to support the millions of individuals who provide care to aging family members or friends. She's internationally recognized expert in gerontological nursing and nursing education. And Dr. Harvath currently leads an effort to build comprehensive services for older adults and their family caregivers at UC Davis Health. So thank you so much, Dr. Harvath, for joining us today, and I'll let you go ahead and get started on the didactic.
Great. Thank you so much, Nika. And I just want to say that the partnership that we have with UC Irvine SQEP has really been such a fruitful one in helping us to move our services forward. So thank you to all of you from UC Irvine to help us. I'm excited to talk to you today about family caregiving in the context of dementia. And I'm really trying to frame my comments to fit for those of you who are in primary care settings. How do you recognize, how do you work with, how do you support the family caregivers who are either your patients or who are caring for one of your patients? Next slide, please. I am pretty sure that this group already knows about what sometimes is referred to as the silver tsunami, but the huge increase that we are experiencing in older adults in this country. But the statistic that is weighs more heavily on me is what's called the parent support ratio. And so we know, I think actually you missed a slide. I think there might be one before that one, Nika. No, that's all right. So the family support ratio describes the ratio between those older adults over age 85, those who are in most need of help for every, or the number of caregivers for every 100 people over the age of 85. And basically, if you saw the slide that I thought I had put in, and maybe I didn't, you would see that in 1950, you had about a 3% chance of becoming a family caregiver because there were not very many older adults compared to those who are typically in caregiving age. But by 2030, that's going to increase to 30%. And like this slide says, if the ratios continue as we expect they will, about half of the families in the US will be involved in providing care to an older relative. And that doesn't include those who provide care to other individuals, children with special needs or adults under the age of 65. Next slide. So I think what's important and what often happens with family caregivers is that they are invisible. I think of them as the invisible member of the healthcare team because the work that they do with older adults is absolutely essential to any care plan that we might develop for that older person. But they often are not seen as the target of our interventions, or sometimes they're seen as somebody who gets in the way. Unfortunately, I think our nursing students across the country hear very early on, they hear nurses say, I could take care of this patient just fine if the family would butt out. And actually, we don't want family to butt out. I think we need family to butt in fact. And so for those of you in primary care, I think the challenge is to try and identify who of your patients either have a family caregiver or are a family caregiver. Oops, I'm sorry. I have a landline that's actually ringing. Please ignore it if you can hear it. I never get calls on my landline. So anyway, with your patients who are older adults may have a caregiver if they have impairment in their activities or instrumental activities of daily living, if they have dementia or cognitive impairment, if they have chronic conditions that require complex medication regimens, oftentimes it's a family member who's helping with that. Or if it's an older adult who's frail and has multiple comorbid conditions. Now, unfortunately, it would be nice if we could just easily identify who is or has a caregiver, but that isn't the case. And we can't just ask patients, are you or do you have a caregiver? Because oftentimes older adults don't see the help that they receive from a spouse or adult children as caregiving. And spouses and adult children often don't see the work that they're doing in helping an older relative as caregiving. They think they're just being a family member. And so I've put some questions here that you could ask to find out whether your patients actually are a caregiver. And usually they're helping with ADLs, IEDLs, they're checking in on them. And over time, they've increased how much surveillance they're doing. Sometimes when caregivers are sort of knee deep in it, they do finally see themselves. Oftentimes that comes after the diagnosis of dementia. Now that my older relative has this diagnosis, oh, that means I am a caregiver. Next slide, please. So according to recent national surveys, as far as we can tell, about 34 million Americans provide care or had provided care in the 12 months prior to the survey. And 15.7, nearly 16 million of them were caring for somebody who has Alzheimer's disease or other dementias. So it's a huge number of people who are doing the care. And the cost, if we were to have to pay for that care, is astronomical. It's in the trillions of dollars if we had to reimburse somebody for the care that family members want to do and do provide for free. Next slide, please. What we also know from some of the research that has been done is that giving care to an older family member can be intense, can be very complex, sometimes involving the provision of care that I went to nursing school to learn how to do, complex medications, injections, tube feedings, trach care. Family caregivers do all that in the home, oftentimes with very little preparation. We know caregivers are a very diverse group in terms of race and ethnicity, but also age. We're seeing an uptick in the number of millennials who are involved in caregiving. And I think there are hypotheses out there that that comes as a result of some of the economic barriers that they've experienced, and therefore they get tapped to be caregivers when that hadn't been the case for a number of years. We know, particularly since the pandemic, but even before that, that social isolation is a great risk for both older adults and their family caregivers, and that it increases the risks that they have for mental and physical health conditions themselves. It's important to point out that caregiving can have both positive and negative impact on the caregiver, and that caregivers are still basically on their own with very little preparation. The study by Reinhardt et al. Found that most caregivers found out that somebody was being discharged from the hospital with care needs with less than 12 hours notice. And so, and during the pandemic, we often didn't allow these family caregivers to come in to learn how to provide the care that they would have to be providing when that older person goes home. Next slide, please. Some of the negative consequences for health that caregivers experience include mental health, depression, anxiety, physical health. Caregivers often put off or delay their own healthcare needs because of their caregiving responsibilities. We know that caregiving can also have negative impact on lifestyle, reduced privacy, reduced time for self. It can have a negative impact on well-being and on family relationships. Particularly in the context of dementia, there can be a lot of challenging family dynamics that happen as a result of some family members saying, I want to remember mom the way she was. It's hard for me to visit her, while others are providing the care on a daily basis. So just recognizing that these consequences can happen is important. Next slide, please. Caregiver stress can take on many different faces and can come from different things. So the stress can occur from the caregiving activities. For example, when adult children are engaged in bathing kinds of activities for their parents, that can be very stressful for them. I had a friend who was a geriatric clinical nurse specialist who was caring for her father with dementia. And when it got to the point where she needed to help him with his bathing, she said, you know, Terry, it is just wrong. I should not be doing that for my father. It just feels like an invasion of his privacy that is, it shouldn't happen. The stress in dementia can come from the behavioral symptoms that we associate with dementia, although caregivers may not see those behavior symptoms as related to the dementia, particularly if they represent an intensification of premorbid personality problems that the caregiver had already had some experience with before dementia came on the scene. Sometimes caregivers, particularly in the context of dementia, can feel manipulated when they don't have a sense about what the older person is or is not able to do for themselves. They can feel increased what we call global strain, because everything is harder when you're also caring for somebody. And so things that happen with your kids or at work take on greater stress because you're already on your last nerve from caregiving. Stress can happen in the relationship between the caregiver and the care recipient. And as I mentioned, negative lifestyle changes and strain from worry. Caregivers worry about the safety of the person they're caring for. They really worry about making a mistake, an error that could cause harm to the person they're caring for, particularly in these complex medication regimens that they sometimes are trying to manage. And so recognizing that stress can come from a variety of different aspects of the caregiving role is helpful as we think about how can we alleviate that stress. Next slide, please. There are things that exacerbate the stress that caregivers experience. The illness severity is one of them. If there are multiple comorbid conditions, that increases the stress. The suddenness of the onset, somebody who had not been a caregiver and suddenly, for example, following a stroke or a fall, has to increase the intensity of the care that they're providing, meaning they have to drop other things in their lives to step in. That can cause increased stress. The amount of change of the patient's status. So in dementia in particular, one of the things that's difficult for family caregivers is as the dementia robs the person of their personhood, of their personality. It's a grieving, a sense of loss that happens with that change in their personality, their personhood. Different demographic factors can have an impact on how much stress. Women tend to report higher levels of stress than men. It's not clear whether that's because of the way in which we measure stress, whether it's because men are, disincentivized in this society to admit that they're having stress or strain. We know that female caregivers often put in more hours of caregiving each week and often have more intensive caregiving roles. So that can also explain it. Other demographic things, interestingly enough, during caregiving and during caregiving for persons with dementia, African-American caregivers often report lower amounts of burden from the caregiving, but they experience more negative sequelae following the cessation of caregiving. And again, we don't completely understand why that is, but it's important for us to recognize that even when caregivers are not reporting high levels of stress, it can be having a negative impact on their health that shows up later. If there are pre-existing psychological problems, depression, anxiety in particular, that can complicate and make caregiving more difficult. And when there are pre-existing physical problems, particularly caregivers who have arthritis or mobility problems, caregiving often continues even when they have those. And if there are a lot of concurrent stressors. We often refer to middle-aged women as women in the middle because they are managing both childcare and parent care, and that can be extremely difficult. Next slide. Fortunately, there are also some things that actually have been associated with decreased stress. Mutuality, or the quality of the relationship between the care recipient and the caregiver, makes a big difference. If there's been a better relationship before dementia and caregiving commences, there tends to be less stress during caregiving. Caregivers who feel prepared for the role, who feel like they know how to do what needs to be done, feel less stressed because they aren't as worried about making a mistake or figuring out what it is they need to do. Caregivers who find caregiving rewarding in some way also report less stress. And those who receive more informal support from friends, families, neighbors, and those who receive formal support from support groups or other places that we can talk about also experience less stress. And there are other interventions that I'll talk to that can decrease stress. Next, please. And then the positive consequences. For some, caregiving actually can enhance the quality of the relationship, where particularly when the caregiver feels like they're able to give back to this person. it can actually help them. I've also seen in a few cases where as the dementia sort of took some of the negative personality traits away, the relationship could improve. An example being, I have a friend whose father experienced a lot of PTSD from his time in World War II. And as his dementia progressed and he forgot about his war experiences, his personality became very sweet, and she actually enjoyed the time that she spent with him when he had been pretty emotionally unavailable to her prior to the onset of his dementia. And so that we can sometimes see an improvement that comes from that. And again, caregivers who find meaning in what they're doing, who feel like they're showing their children that caregiving is important, or where they feel like it allows an enhanced relationship. They can feel rewarded from the care that they're providing, and it actually offsets the amount of negative consequences they experience. Next slide. There's been a ton of research on interventions to improve family care, particularly in the context of dementia. The caveat I would say is that we have not done a good job of including caregivers from traditionally marginalized groups, caregivers of color, LGBTQ caregivers, caregivers in rural areas. We don't have as much of a research base on that. And so it's difficult to know whether or not these interventions can make a difference. But psychoeducational, both at the individual and group, can help caregivers in the context of dementia. The more they learn about dementia, the more that helps them manage some of the challenging aspects of that. Respite care, both small amounts of respite during the week where somebody comes in for a few hours so the caregiver can go to their healthcare appointments, run and get groceries, just have time for themselves. Support groups can be helpful. And I say can be helpful. I think we probably, this is one where one size doesn't fit all of support groups. Some caregivers prefer to be in a support group that's all wives if they are a wife caregiver. Some prefer to be in a group that's all adult children or gender specific groups. Some caregivers want to be in groups that are determined by the stage of the dementia, that they want to know, they want to talk to other caregivers who are dealing with the early stages of dementia or the later stages of dementia. There's some caregivers who don't want to go to a support group at all because they don't want to hear about the problems that other people have. And so I think just asking caregivers before referring, would you find it helpful if you could talk to other people who are in a similar situation? If the answer to that is yes, then encourage them to seek a support group. There are also differences group to group. Some facilitators, I think, are better than others, quite frankly. And so that can make a difference. And so if somebody's gone to a group and they didn't find it helpful, they may check out another group and that might be helpful to them. We also know that in-home services can also make a difference. Things like Meals on Wheels or Mom's Meals. A caregiver was telling me about that she thought were pretty good. Having a bath aide can come in sometimes can help with that. Somebody who just comes in and gives, again, the respite, the caregiver a break can also be helpful. So that's the good news, is that we do have some interventions that can make a difference. The affordability of it can be a barrier for some. In an interesting twist, usually caregivers where there is a qualification for Medicaid or Medi-Cal are often able to access additional services that caregivers of higher income groups are not eligible for and often can't afford themselves. There is in California, the caregiver resource centers. There's, I think, 13 of them across the state. And they are for that group of more middle and upper income where they may not be able to afford services, but they are not eligible for Medi-Cal services. And the caregiver support resource center in your geographical area, if you're in California, can be a tremendous support. They make a positive difference for those families. Next, please. One of the things that I also want to point out that we often think about the difficult decisions that come when somebody's at end of life, thinking about invasive medical interventions, DNR status, and sometimes that can be made more complicated in the context of dementia. But in fact, caregivers face many difficult decisions when they're caring for a family member. Can my dad be left alone? Can they manage their medications? Should they be driving? Are they safe living by themselves? Do they need a higher level of care? They also wonder, they question and make decisions about their ability to provide the care. How do I take time off work to care for my family member? Is this the time that I should think about using these services, or should I wait? Are things going to get worse and I'm going to need those later? And so recognizing that caregivers are facing a lot of difficult decisions can be an area that perhaps you assess for them. What are the difficult decisions and how can they get some help in making those decisions? Next slide, please. One of the things that I've been able to do for the last year when UC Davis Health has embarked on developing increased services for older adults is we opened a healthy aging clinic that focuses particularly on dementia care. And as a part of that and the Family Caregiving Institute, we've opened a clinic for family caregivers. And so another colleague and I do 1-to-1 or 1-to-7, because sometimes the family all shows up for our consultations, consultations with family caregivers. And I would say probably the biggest issue that comes up, or the one that causes them most distress, is when their concerns for the safety of their family member are in tension with either the expressed preferences or the autonomy of the person with dementia, or the ways in which they believe quality of life is important to them. And these decisions really can be a huge variety of shapes and forms, but you'll recognize them that it's, I want to keep my family member safe, but I don't know what to do. That's not what they want to do. And so we've developed a framework that I think resonates with family caregivers about how to have those discussions. Next slide, please. And we talk about it as a three-legged stool. And what I talk to caregivers about is you can try to protect the safety of your family member. You can try to protect their quality of life. And you can try to protect their autonomy or respect what their preferences are, but you can't do all three to the same degree at the same time. It's just not possible. I also have sometimes frank conversations with caregivers about how there are limits to what you can do to protect your family member. Oftentimes we opt for what I call the illusion of safety. I'll put all these things in. I talked to a caregiver who had installed cameras all over his mother's house so that he could monitor when she might fall. And he was driving himself crazy watching the feed from these cameras, trying to determine whether or not she fell. And he confirmed. I said, so what's the last thing you do before you go to sleep? And he said, check the camera feed. And I said, the first thing when you wake up, check the camera feed. And he lived 3 hours away. So as soon as he was going to get to her, if she had fallen, was 3 hours. And it drove him crazy. And I said, you could be right next to your mother and she could fall. What you're talking about is how quickly somebody picks her up, or how quickly somebody responds to a different emergency. If she's broken a hip or sustained an injury to her head or some other injury, how quickly somebody's going to respond to that. But you can't prevent your mother from falling if she's falling. And it's a hard reality, but it actually frees up some I think, mental space for caregivers when we recognize and we tell them they can't protect them from everything. And probably the price to pay for trying to implement safety is a pretty dear one that I think often older adults and older adults with dementia do not want on their behalf. And so when we talk about balancing quality of life, autonomy, and safety, it becomes more manageable. And caregivers are going to vary in terms of how much risk to safety they're willing to accept. I met with a caregiver recently whose mother narrowly escaped from the campfire in Northern California, and she had absolutely no capacity to accept risk on behalf of her mother anymore. She spent all that capacity with the fire, and so she was much more interested in moving her mother to a memory care than other caregivers I've spoken to, who recognize that quality of life and autonomy and staying in their own home may be important. And if it's okay, and if we're not going to judge them harshly for the risks that are involved in that, that's the decision they would like to be able to make. And I would encourage you to have this kind of a conversation with caregivers if they're expressing these kinds of concerns, and not just default to safety. I think it's hardwired in all of us to want to protect those who we care about. And yet there are limits. I remember telling my daughter as she was growing up that her desire for independence was always going to outpace my comfort in her independence, and that we would need to continue to negotiate that. She's 26, she's launched. I still worry about her, but I know that I cannot protect her from every bad thing that could come along. When I dropped her off at college and I was driving back home, I drove past a hitchhiker and burst into tears because I'd never told her not to hitchhike. And I was, certain that that was a failing on my part. When we give ourselves and our patients who are caregivers permission to not protect the person they're caring for from every bad thing that could come along, I think that eases their worry dramatically. Next slide. So an example of how we use the three-legged stool metaphor in clinic is, when somebody says, do I have to move my dad to memory care? I talked to a caregiver one time, and she said, my dad's physician told me that he can no longer live at home and that I have got to move him to memory care. Now, she had a lot of help in the home. She had caregivers who were there 14 hours a day. They would come in the morning, get him up out of bed and dressed for the day, stay with him all day, get him in bed at night, and then leave. They'd lock the door as they left, and there were cameras and alarms on that the daughter was able to monitor. And she said, my dad said, I'm going out feet first. I'm not leaving this house, not until I die. I'm going to live in this house until I die. And in that way, as we picked apart, what would the safety be in memory care? Well, falls still happen when you're in memory care. Somebody responds sooner, maybe. Through the pandemic, we know that memory care and other congregate care environments were actually not very safe places for older adults to be. And when norovirus and other things sweep through a memory care facility, that can wreak a lot of havoc and expose older adults to things they might not otherwise be exposed to. There is some opportunity for autonomy in memory care or other congregate care environments, but it's severely limited. And lots of times the concerns for safety override autonomy in those environments. Quality of life, I think it's important for us to understand from the patient and caregiver's perspective what contributes to quality of life, and work to try and maximize that. And when there is no more quality of life, then think about how can we avoid really invasive interventions that prolong a life that no longer has quality for the older adult or for their family. These are hard decisions. There isn't a single right answer, but I think it's important to sort of tease out some of the complexity in order to respond to the concerns that our patients with dementia and their caregivers experience. Next slide. I think it's also helpful for caregivers to know that their situation is not going to be static, that it is going to change over time as the dementia progresses, as their skill in caregiving increases. Things will be different. There'll be good days and bad days. The problems that they are encountering today are likely not to be the same ones that they're dealing with 6 months from now. And that can be a good thing, and it also is a bad thing because it means that the dementia is progressing. And the behavior symptoms fade as the dementia continues to progress because the older adult is less able to resist or do things that may present challenges for the family caregiver. But with that is often accompanies the loss, the grieving the person, grieving the loss of relationship with that person. So those changes over time can be good news, bad news things for caregivers. But I think it helps sometimes that they understand that things will change. Next slide. Caregivers often ask, well, when should I stop doing what I've been doing? We'll get questions that I'm sure you do too about medications that the person's resisting taking, and how hard should I work to try and get them to take that? What I try to tell caregivers is that success is often a matter of trial and error, and you can do something and it works today. It may not work tomorrow, but it may work again next week. Anything that they do that increases anger, agitation, or resistance should be avoided. That seems common sense, but sometimes caregivers feel compelled to continue to push because they think it's important to get this vitamin in, or even this blood pressure medication, and sometimes stopping, going away for a while and coming back later is a better strategy than continuing when things escalate. When to change strategies, and this includes perhaps when to think about whether neuroleptic medications, psychotropic medications may be indicated. If the caregiver's health is threatened, we may need to think about sedating the person with dementia a little bit more. When the care recipient's well-being is threatened because the chaos in the relationship is escalating, perhaps something needs to give. When the caregiving situation, so I've talked to caregivers where they were both staying in senior housing, and because of the dementia-related behavior symptoms, they were being threatened to be evicted, knowing that it would be difficult for them to get into other senior housing. And so if their caregiving or their home situation is being threatened, we may need to take an increased role in how aggressively we're treating some of the dementia-related symptoms. And again, if there's escalation of agitation or symptom intensity, sometimes the caregiver is not the right person to be providing that day-to-day, hour-to-hour hands-on care, and having another caregiving situation, memory care, may be indicated. Next. I think it's important to also be able to identify when is a caregiver at risk. And when you hear caregivers say things like, my husband's condition gets worse no matter what it is I do, it just seems to get worse. No matter how much I do, it isn't enough. When they feel as if they're the only one who's experiencing stress and everybody else is doing a better job at caregiving than they are. Or if they say they don't have a place or time to be alone. Over the last year, I've seen several caregivers where their complaint was that the person they're caring for was narcissistic, and no matter how much they did, it wasn't enough. And when we probed, I asked them, well, it sounds like you're already, maybe giving 120%. And the caregivers will say, yeah, and it's not enough. And I said, and if you gave 150 or 200%, would that be enough? And they'd say, no. And I said, well, maybe you should only give 50%. Maybe you shouldn't be giving it all. If it's not making a difference, no matter how much you're doing, pull back. And that actually with several caregivers that actually worked quite well. And they didn't believe they were putting the person with dementia in any greater risk, but rather they just weren't responding to every request to do something. And that made a big difference for them, feeling like they didn't have to respond to every request to do something. Next slide. Other risk factors that may be important to identify is if caregiving is significantly interfering with work and the caregiver's employment status is being threatened. If they start to feel that it's selfish to think of their own needs, or they are delaying urgent health care that they need. If their coping methods have become destructive, drugs, alcohol, other abuse, or if they report that there are no more happy times when they are with the person with dementia. I think those are all warning signs that we need to pay attention to and suggest that maybe a break in caregiving needs to happen or a different caregiving situation needs to be planned for. Next slide. I try to tell caregivers that they need to put their own oxygen masks on first before helping others. The same thing applies to health professionals, by the way. We often don't do that ourselves. And also that, and caregivers can sometimes resist that, saying, I don't have time to take care of myself. And so what I will suggest to them is that, your family member is going to need you around for the long haul. And it's not going to help them if your health deteriorates and you're not able to care for them. And so we need to figure out and explore ways for you to be able to take care of your own health so that you can be there for them for the long haul. And for those caregivers, that seems to help, where prioritizing their care in service to the care recipient might be a reasonable way forward. And so that's sometimes what I'll offer to caregivers. Next. I would be remiss if I didn't just say something about caregiving during the pandemic. You probably all know that older adults bore a disproportionate amount of the burden of illness during the pandemic. Caregivers did too. They became socially isolated, and the community resources that may have been giving them a break closed down, dried up, withdrew. And while some of them tried to stay in contact with caregivers, the caregivers often resisted anybody else coming into the home for fear that they would bring the coronavirus to them or to the person they're caring for. One of, I think, the hardest parts for caregivers was that hospitals across the world closed to visitors, and they made exceptions for parents of minor children and partners of pregnant women. And those are appropriate exceptions because we know that children and pregnant women do better when they have support, but so do older adults, particularly frail older adults and those older adults with dementia. And caregivers to persons, to frail older adults were not given the same exception. And what resulted is some of them declined and delayed bringing somebody to the emergency department who needed help. We saw increase in risk for abuse and suicide among caregivers and older adults. I actually experienced that myself. My partner was hospitalized at the beginning of the pandemic and was older than me, had multiple surgeries, complications from cancer. And at one point when I was in the hospital with her, I got kicked out. And I was gone for about 18 hours before I was able to pull enough strings to claw my way back in. And I know that many, many caregivers across the world were not afforded that opportunity. And when they brought an older relative to the hospital, they didn't know if they'd ever see them again. And these are not necessarily people who were experiencing COVID, where visiting could be, really problematic. And I just point out, I believe that's ageism in action when we treat the caregivers for older adults different than the caregivers for children and pregnant women. I think that's probably a definition of ageism. And again, I would just draw this to your attention to recognize that we need to be advocates within our own health systems in order to have policies that promote the caregivers to participate in the healthcare of their older relatives, particularly with those with dementia, because they don't do well in our healthcare systems. Next slide. How are we doing on time? So these are my